In these scenes, we can see a case of couching in cataract surgery. Topical anesthesia, minimal incision, quick surgery, but with inadequate technology in an obsolete environment by today's standards, with lack of precision and risk for the patient. In these scenes, José Ignacio Barraquer, at the beginning of the 20th century, we can see how cataract surgery was performed through large incisions, large instruments, and uncontrolled surgical trauma. But in the end, the cataract was removed from the eye. Cataracts were first operated in modern times by intracapsular techniques at the beginning of the 20th century. Today, this surgery is no longer clinical practice and was substituted by extracapsular surgery, which is currently still in clinical practice in many countries of the world. The majority of cataract patients are currently operated by standard coaxial or microcoaxial phacoemulsification surgery techniques. This surgery involves incisions of 3.5 to 2.2 millimeters and includes the implantation of the intraocular lens through this incision size. To the right of this curve, we can see how a percentage of surgeons are currently using micro-incisional techniques, which are those which use incisions of less than 1.8 millimeters for the whole cataract surgery procedure. Going beyond this practice and even further developed, we can find surgery performed through 0.7 millimeter incisions known as micromix. How should ideal cataract surgery be performed? We need to imagine an energy source which can soften the cataract and then puncture the cornea with 2 microneedles to eliminate the fluid in the capsular bag and substitute it for a substance with optical qualities. However, mix is a step forward in pursuit of this ideal surgery. Mix surgery is no doubt the most advanced technique at this moment in time. However, this surgery, which is based on the use of incisions of less than 2 millimeters, has its drawbacks. In the first place, the incision is performed with different instruments, and not all, as we can see here, cut the same. Not all incisions are equally perfect. Although these knives are calibrated, how accurate are they? What depth do they reach? What incision design do they create? The incision is never the same and controlled. Here we can see incisions of 0.8 millimeters, and that they are practically punctures. But these incisions never have a stable width, even with the use of diamond knives. What is the depth at which we should locate these incisions? And is this the correct incision design? Capsular hexis is the next stage. To carry it out with the needle is no doubt practical. But is this an updated technique? Is this technological? Can we control it properly in every case? To carry it out with micro-incisional coaxial forceps is a far more perfect technique, but how can we guarantee the centration of the capsular hexis, the quality of the edges, and the stability of the diameter? Today, this is still impossible to guarantee. On the 8th of June 2010, a new chapter in cataract surgery began with the introduction of the use of femtosecond laser to perform all of these surgical steps. In the image, we can see the surgical team, formed by Professor Alió, Dr. Zoltán Nagy, and the engineer Johann Brennan from the company Lensex. Our purpose was to use this new technology to carry out sub-1 millimeter cataract surgery. Here we can see the team planning the strategy to position the incisions, their diameter and their length and design. The incisions were to have a diameter of 0.9 millimeters and a length of 1.7 millimeters. Here we can see the programming of the capsular hexis with respect to the diameter and centration. We can also see in the image at the top right how this is performed observing the depth of the capsular bag. Here we can see the structure of the incision and how the steps are initiated and continue at a rapid pace, step by step. Here we can see how the nucleus is softened and fragmented into 4 sectors. Immediately afterwards, the capsular hexis is performed according to the pre-programmed parameters. And then, immediately after this, we can see how the 1 millimeter incisions emerge, first to our right and then to our left, with the precise programmed width and length. In this image, we are going to see how the capsular hexis is removed, exposing the fragments of the nucleus that have been created. The already predetermined capsular hexis separates with much ease, leaving the uniform edges exposed and a well-centrated capsular hexis with exactly the planned diameter. With instruments of 0.7 millimeters, working through incisions of 0.9 millimeters, we are now eliminating the fragments using the excellent fluidics of the Bausch & Lomb Stellaris platform, which is the most efficient for femtomix surgery due to both its vacuum power and fluidic stability by the use of pressurized infusion available in the Stellaris platform. We are using our instrument from Microsurgical Instruments, MST, called the irrigating stinger, with which we obtain downward irrigation assisted by the 0.7 millimeter phaco tip with 30-degree angulation, and we conclude the surgery with incisions which have been smaller than a millimeter wide. We are going to inject at this moment a mixed lens, in this case the Acreus MI60, which is a lens specifically designed for mixed surgery. Due to the characteristics of the material used in this hydrophilic lens, it can be folded under pressure inside the adequate injector using the corneal tunnel-assisted injection technique. We can observe how the lens enters the capsular bag in a smooth and simple way. The surgery finishes with a 1.6 millimeter incision, as shown by the use of this gauge caliper. The 1.6 millimeter caliper penetrates inside the eye, but the 1.7 millimeter caliper does not enter, given that the incision has a smaller diameter. Finally, the viscoelastic is removed from inside the eye. In summary, we can conclude that microincisional surgery, assisted by femtosecond laser, constitutes a new step forward in the search for excellence in cataract surgery. It has impressive precision and predictability, allowing design of the incision size and the capsular hexis previously unachieved. The effect of these incisions on the topography of corneal aberrations is neutral, and so does not distort the optical quality of the cornea. We may perform any incision design, and in addition, the softening and/or fragmentation of the nucleus effectively for cataracts clinically classified up to grade 3. We can predict that the future of mixed cataract surgery, assisted by femtosecond laser, will be the future of our practice. Today, the surgery carried out through 2 incisions of 0.9 mm width and 1.7 mm length, and an accessory incision of 1.7 mm for the lens implantation, allow us to complete this surgery without inducing astigmatism and without incision hydration, thanks to their stability, enabling the perfectioning of cataract surgery to limits unknown today. With this, we have achieved a level of precision and control in cataract surgery previously unknown. Many thanks for your attention.